Good afternoon, and welcome to the 7th session of the Beyond Prescribing Your Role in Antibiotic Stewardship Learning Series. As you all probably know by now, I'm Andy Romero, the manager for this project. And if you were unable to attend any of the previous sessions, the recording and tools have been posted to the Health Insight website. We're excited to have all of you with us again today. A couple of housekeeping details before we start. If you're viewing on your computer but listening on your phone and you haven't already linked your computer and phone, please do so now. Those instructions were on the screen previously and were sent in an email from Elaine yesterday. Please let us know who's on the webinar today by entering your name and the facility you represent in the chat. If you have multiple people in the room, please enter the names of everyone in the room so that we have an accurate count of participants. And we're also going to need that information for people who are requesting CME or nursing home administrator continuing education. Please make sure you mute your microphones to reduce the background noise by clicking on the microphone icon at the bottom of the Zoom meeting screen. And you may enter questions in chat at any time during the presentation. It is a fairly dense presentation today, so we don't have a lot of discussion periods, but there will be a question and answer session at the end of the session. And this session is being recorded and will be available on the Health Insight website. The question and answer portion at the end will not be posted to encourage sharing, and you will receive a notification when the recording has been posted. So these next couple of slides are our disclosure slides that we have to have for continuing medical education. We have a faculty speaker disclosure about no relevant financial relationships and a planning committee disclosure about no relevant financial relationships, and then the nursing home administrator approval. We're excited to have Dr. Susan Kelly back today to facilitate today's sessions. You can reference the first 2 sessions for Dr. Kelly's bio. And without any further ado, I'm going to go ahead and turn the session over to Dr. Kelly.
Hi, everybody. Today we're going to be talking about microbiology, so it's a little bit of a cram course. But I want to stress to everyone that you have a great resource available to you, which is your laboratorian. And this person actually has a lot of knowledge and expertise that you should be making the most of. So cultivate a relationship with your laboratory, especially if you have a local lab where you can call and speak to people. I realize that for some people who are using a out-of-state lab, that may not be so easy, but take advantage of what you can. So we're going to talk a bit about antibiograms, using cultures appropriately, and then we're going to talk on a slightly different topic about communicating between facilities about residents who have positive cultures for infection or positive indicators such as surveillance cultures for colonization, especially with resistant or problem organisms. So know your lab. Who does your microbiology? What's in your contract with them? What can they provide you? Often lab websites have a lot of information on them about how to do cultures and some explanation about how results are reported. What else do they provide you? So I want to show you one really nice service that is provided by our local large laboratory, Tricor, which is their weekly infectious disease report. And this is kind of good to share with your clinicians because they'll be saying, oh, look, everybody is calling out sick with this or that, or everybody has a cold. And you'll be able to know from these weekly reports, has influenza hit in New Mexico yet? Is it on the wane? Is it up or down? And then other viruses such as RSV, respiratory syncytial virus, you can see in this month of February is pretty high. We think of those as pediatric problems, but actually if you look at long-term care patients, significant number of them have infection with RSV, which is bad enough to trigger pneumonia or exacerbation of COPD and hence admission to hospital. So it's good to know what's going on in your community. There's an RSV season the same way that there is a flu season. And then you have parainfluenza, which is croup, and you have adenovirus, which is fairly rare, and you have HMPV, which is human metapneumovirus, which is kind of a new thing. And again, it's kind of a coughing crud. So a lot of this was published with a view to the pediatric population, but actually your long-term care patients are also vulnerable to fairly severe disease with some of these viruses that are going around. So when you go to lab website, your out-of-state lab, Lab X, I'll call it, according to their website, customers can be provided with monthly reports that identify the type and frequency of positive cultures in your facility. That's a nice service. They should also provide you with an antibiogram. And this is an out-of-state lab. So this should be in your contract. It's what it says in their websites. Take advantage of that. Don't reinvent the wheel and give yourself busy work listing all your positive cultures on an Excel spreadsheet if they can actually give you a monthly report and see what format that might be in. Antibiograms. These are an educational tool to inform clinicians of the resistance profile in the facility. If you're large enough to warrant a facility level antibiogram, or in your area, within large facilities, geographic areas can vary, and then you can have areas that are high risk, like ICUs, have more resistant organisms. It's also very important to know there are large regional differences in antibiograms across the country. And so if you have a prescriber who was trained in one area, and this is very common in medicine because so many of our residents do come out of the big areas with a lot of training hospitals like New York, LA, Chicago. Prescribing habits that they learn there may not be appropriate for New Mexico. So New Mexico State Department of Health is going to be coming out soon with a state antibiogram for New Mexico, which is kind of interesting. So let's talk a bit about microbiology with bacteria. When you look at your antibiogram, it's going to be divided into two basic groups of bacteria. Your gram-positive, which are called that because they retain the blue stain with the gram stain, and your gram-negative, where the blue stain gets washed out and all you're left with is the red stain. So your gram-positives are strep, staph, and then Enterococcus, which used to be labeled under the streps, but now is its own species. And unlike the others, which are above the belt bugs or skin bugs, Enterococcus is in the bowel, as is suggested by the name, and there from the bowel it can get into the urine. And then you have your gram-negatives. So these will often be in the urine, they're in the bowel. In sicker patients, they can cause hospital onset pneumonia, and of course a whole host of other infections like enteric illnesses with salmonella. So this is your two basic groups to look at. So we're going to take a closer look at what's available on the Tricor website. They just put these up with data from 2017. So we'll take a look at one and then the other. Okay, so this is non-urine isolates and gram-positive isolates. So let's take a peek. They have put up some resistance profile for Streptococcus pneumoniae, the #1 cause of bacterial community-acquired pneumonia, and then Staph aureus in our area. So they have determined if I want to look at Staph aureus, I'm kind of interested in how much MRSA is in our area. So I'm going to be looking at the susceptibility to cephalexin, and I'm looking at, okay, Penicillin is not tested. It doesn't actually have the oxacillin or nafcillin susceptibility here because those aren't drugs you're going to be using in an outpatient setting most of the time. But it looks like we've got about 40% MRSA and 60% is susceptible to cephalexin, which is Keflex. So that's a good thing to keep in mind if you're looking at skin and soft tissue infections in the community. The strep pneumoniae, you can see there is the susceptibility to penicillin is about 85%. But because of the way these susceptibilities are determined, you're probably still in good shape if you use a high-dose penicillin or ampicillin sulbactam for community-acquired pneumonia in our area. So they stick some guidelines on here. For your purposes, you might be interested in the cellulitis guideline if the patient can be treated as an outpatient, the guidelines for purulent skin and soft tissue infection, mainly incision and drainage if the patient's not systemically ill. And there's a guideline there for pneumonia with comorbid conditions. So next slide.
Do you want to do the other antibiogram?
Yeah. So we're going to look at the other, let's see, you want, okay. So here's our outpatient antibiogram for, just click on the tab at the top of the page. There you go. On the outpatient, you see that outpatient. There we go. So here we are with urinary tract infections. Let's blow it up a little bit. Okay. Because I'm peering here with my myopia. This is where things are going to be a little bit different from with the community and you all in the nursing home. Let's look at a classic urinary tract infection bug, E. coli, which is the most common, almost 5,000 isolates. And you see the susceptibility to nitrofurantoin is very good. And so is the susceptibility to the Vaseline, basic first-generation cephalosporin. So they give you a guideline here. It's for uncomplicated UTI. This is really for younger, non-pregnant women. Without catheters. Nitrofurantoin is recommended. Bactrim in our community is a fair choice for a second line. And then fosfomycin, which is a urinary tract only drug, is a fair choice for a third line. But this is all for patients with no systemic symptoms of fever, chills, elevated white count, or sepsis. There's a few gram-positives turn up in the urine. Most of them are Enterococcus, as we mentioned, faecalis. And for Enterococcus faecalis, the ampicillin is highly susceptible, as is the nitrofurantoin. And for Enterococcus faecalis, it tends to be the more resistant species. Ampicillin is not so susceptible. And then there's a few Staph aureus in the urine, and we're going to talk about that specifically. So while these are available to you, these are really aimed at the office practitioner. And so let's go back to the slides. They're interesting because it tells us a little bit about what's going on in our outpatient community, but it's not clear how many of these data represent long-term care facility residents and how many data are really based on ambulatory and pediatric patients. The guidance that's given there is for empiric therapy only with antibiotics. You would always want to be checking your culture results, and the gram-negative recommendations for UTI are really for an uncomplicated UTI. So when you get your antibiogram, you're going to be wanting to interpret it in the context of your patients. So let's talk about a few more things about microbiology. So why not always use the drug to which the bugs are the most susceptible. Oh, 98% is better than 95%, especially with, say, Strep pneumoniae. If you have an organism in a body site, such as urine or lung, and you're able to dose an antibiotic high enough, it is often appropriate to use that antibiotic as first-line therapy. Not all isolates test as susceptible. The reason for that is that the lab has to give the worst case scenario for resistance. So Strep pneumoniae can also cause meningitis. So the lab has to say, if this patient had Strep pneumoniae in their meninges, where it's really hard to get high-dose penicillin in there, we can't get that level of penicillin high enough to be susceptible, or in the blood, for instance, so we can't call it susceptible. So increasing the dose works for some drugs and some types of resistance. It's very specific. High-dose amoxicillin is now recommended for Strep pneumoniae in young children causing otitis media and so forth, where you can reach high concentrations there. But many drugs, increasing the dose does not work. You can't increase the dose of fluoroquinolones. It does not work for the urinary tract. The mechanism of resistance is not amenable to increasing the dose. So when you get your own facility's antibiogram, you're going to be wanting to look at it, create guidelines and recommendations for empiric therapy. That means what you might start the patient on for something appropriate to your population. And you may want to provide first, second, and third recommendations so the clinicians can tailor their decisions to kidney function, allergies, and so forth. So for a urinary tract infection, it might be appropriate for you to say, in this facility, because it looks like 85% of our isolates are susceptible to cephalexin, you can use Keflex for a UTI. We're trying not to use fluoroquinolones because of the risk of C. diff in this facility. Bactrim might be an option depending on the susceptibilities, but you're going to have to put a little disclaimer, watch out for the kidney function. Also, an important thing on your empiric recommendations, think about putting down a duration that is consistent with current recommendations, because many clinicians will just automatically write for the 10 to 14 days, whereas urinary tract infections in men with catheters can often be treated, for instance, for 7 days, according to the most recent literature. So now we're going to do a quick poll talking about how you use cultures. Do you use protocols for cultures in your facility that minimize false positives and false negatives? So do you think about culturing? Are there criteria that patients have to meet before cultures are sent? Or is the culture kind of the first part of the patient evaluation? Does anybody evaluate their culturing practice? So let's see what people think. Do you have protocols for sending a urine? So this is where some people are strong on this, but a lot of people don't feel that strong that they have good protocols to support their culture practice. Okay. So what does the lab want? The lab wants to communicate with you. They want you to get the best possible result so that it doesn't waste people's time and money, and they want you to get a really good specimen. Bacteria are finicky. A lot of our culture mechanisms, our culture practices are actually 19th century, I hate to tell you. So when we're teaching residents and students, they think that the cultures just magically appear in the computer. They don't know that at the lab is still often a painstaking, hand-done process for much of the plating, and that some things are being automated, like susceptibility testing, but not everybody is just doing PCR on everything out there and getting all kinds of information. So some labs do have broad spectrum PCR capability, but many are doing classic microbiology. So the lab will tell you how to do the specimen collection. The other important thing is refrigeration. Urine is a culture medium. If that urine sits on your counter and warms up on a hot day, those bacteria grow. They're happy. So just like food, to stop bacteria growing, you have to put it in your fridge. So your lab is happy to give you a lot of information about how to do proper culturing. Now here's a case in point, C. difficile, a huge case in point where communication and understanding between the lab and the clinicians ordering this test is essential. So from the lab's point of view, the purpose of a C. difficile test is to confirm the clinical diagnosis of C. difficile diarrhea. If you go running around doing a C. difficile test, especially a PCR assay, you will find all kinds of people positive. They will not be having diarrhea. So that is a false positive test. Similarly, the old EIA test for toxin also generated a tremendous number of false positives when it was used inappropriately. So know the resident's symptoms, know the resident's history, know your test, know what you're sending. So here are some basic symptoms. Does my patient really have diarrhea? Diarrhea is defined as 3 liquid bowel movements in 24 hours. Could my patient have paradoxical diarrhea? This is liquid stool passing around an impacted hard stool. You can often feel this on abdominal exam. Have a good record of bowel movements, know the patient's bowel habit. And then the other thing that you will see perhaps more in office practice is patients who have had C. difficile often have irritable bowel syndrome. Irritable bowel syndrome is a functional bowel problem where you'll often have alternating diarrhea and constipation. The hallmark is bloating. It often has onset following an episode of infectious diarrhea, like traveler's diarrhea. And patients who have had C. difficile are terrified of getting it again. And so one loose stool will often have them raising the alarm, I've got C. diff again. Be patient, see what's going on with their bowel habit. Are they bloating? Do they have feelings of incomplete voiding and straining? Do they have a history of irritable bowel syndrome that could be misleading you? Watch them for a little while. So one way to communicate objectively about the stool is using the Bristol stool form scale. Showing this picture would have cost $1,500. So we have a link here for you showing the picture. So the Bristol stool scale was developed in Britain, and it has a lot of references to sausages and other food types. So level 1, severe constipation, the stool is like nuts. Level 2 is lumpy and sausage-like, mild constipation. Type 3, sausage shaped with cracks in the surface, normal. Type 4, like a smooth sausage or shape. See, the British are very obsessed with sausages. And then when you get towards diarrhea, number 5, type 6, mushy with ragged edges, and type 7, liquid consistency with no solid pieces, like soup. So everybody needs to be able to describe stool in a consistent way. And in fact, one of the ways that in the UK they managed to bring down their numbers of C. difficile cases quite dramatically was through having a rigorous communication from facility to facility about the patient's bowel movements as described on the Bristol scale. So we all know what we're talking about. So the other important things about C. diff and sending a test is to know what other drugs the patient is on. Proton pump inhibitors put you at high risk for recurrence of C. difficile. Non-steroidal anti-inflammatories, that's a new finding also. Many patients are on stool softeners or just got some kind of purge for imaging in the hospital or something like that. You want to discontinue all these drugs. There's a lot of other medications that cause diarrhea. Antibiotics alone can cause changes in bowel habits that are not C. diff related. And then particular antibiotics like clavulanate, which is in augmentin together with the amoxicillin, also causes diarrhea. And then there are certain chemotherapy drugs that cause tremendous diarrhea. So be aware of all the drug causes of diarrhea. I can't tell you how many times we would go into patients' rooms for C. diff and then review the patient's chart, and they were getting stool softeners. So the other thing is to know what your test is. This is what's on Tricor's website. The test code is C. diff. It has a CPT code, and they do a reflex protocol. So they start out with this combination test with C. difficile toxin test and the antigen test. And then if either one of those, if both of those are positive, they call it positive and stop there. If both of them are negative, they call it negative and stop there. And then if they have discordant results, they will be flipping on to a C. difficile PCR. And it looks like they've also added they just have flipped it to PCR. We did a study on this at UNM when they started this protocol. Only 9% of the tests had to be flipped to a PCR. So that means 90% of the time, we were able to tell by the toxin or by EIA together with the antigen showing that C. diff was present and making toxin, that we had C. diff there, and if those were both negative, C. diff was not there, and the test performed very well. What we did find is that the understanding of this reflex protocol was so poor that if we put all the results, including the second phase result with the PCR in the chart, it caused tremendous confusion. So we just called it positive and negative. So you may be getting the same kind of result. Not all the 3 tests are going to be shown, but that's the lab's interpretation of the testing sequence. So other things that they want for a valid test, they want a refrigerated specimen that is no more than 48 hours old. If a specimen for C. diff is not refrigerated, the toxin can degrade and you have a false negative. So one thing that's an easy audit to do and may improve your laboratory testing for C. difficile would be to do a chart review and say, were laxatives prescribed for this patient in the 48 hours prior to sending the C. difficile test? Clearly, there was a lack of communication or a failure to know what was going on about the patient. Somebody got called on the phone. They didn't have the full picture of the patient, and the patient just had diarrhea because of laxatives. Did the patient have a recent C. difficile test done within 7 days or 14 days? Are we repeating a diagnosis? It's actually very hard for patients to go from having a negative C. difficile test with an antigen or a PCR and then develop full-blown diarrhea within 7 days. The patient typically has to get colonized, and the C. diffs have to multiply for a while before they'll come down with diarrhea. And then how good was the documentation on the diarrhea? Were there 3 bowel movements in 24 hours? Were they well described? How did it meet the criteria? So that's just a really nice quality improvement thing you can do as part of your antimicrobial stewardship to make sure you're not putting everybody on meds all the time for C. difficile that is not real C. difficile. Here's another polling question. We have a procedure to look at cultures for bug-drug mismatches based on antimicrobial susceptibilities. So we're making sure that the patient is not getting an antibiotic to which their bug is resistant. This might be quite common in urinary tract infection, where people are used to being able to prescribe, say, ciprofloxacin, but the bugs are resistant. One thing that's happened in nursing homes is that there has been so much use of fluoroquinolones in this population that a lot of the E. coli are resistant to only Cipro, and they're susceptible to ampicillin, Bactrim, things like that, you know? So that's a phenomenon that you might see. So it's kind of across the board. Some people have a good system in place for looking at the bugs and the drugs, and some people don't. So let's talk a bit about microbiology reports. They are very difficult to read in most cases. They include a tremendous amount of information, and not all of it is really relevant to what you want to know. So we're going to talk a bit about the minimum inhibitory concentration. That's the amount of antibiotic needed to kill the bug in vitro. And the lab has interpreted that for you and put down S and R for susceptible and resistant, and sometimes intermediate. And the MICs will vary for all different drugs. So for instance, you can have a MIC, you can reach a concentration in the blood of ceftriaxone very high, in the high hundreds to thousands. You don't get resistant to ceftriaxone until your minimum inhibitory concentration is about 64. So cephalexin, similar drug, the MIC, you can't reach very high levels, and so your resistance often cutoff will be around 2. So MICs are specific to different drugs and different bugs. So focus on the lab interpretation and the lab comments. So the MIC, this is an old photo from a micro textbook. This is tube dilutions. Now this is done in microtiter plates and read by a computer. So in the top, figure A, there's growth of bugs until you get to a concentration of 8 micrograms per ml, then no more growth. And then the resistant organism grows all the way across, even as you get to those higher numbers. Now you can't keep going up forever on the numbers. So in the lab, you might be able to kill that bug when you got to 2,000, but you can't reach that level in the human or it's toxic. So we have to be realistic and say, this is resistant, because we can't reach any higher level in the person. So this is what really drives everybody bonkers about lab reporting. You see this long list of drugs there. And the first thing you'll see is it's alphabetical. They're not even grouped by drug family. unless by chance. Some of them are IV, some of them are oral. You know, what am I looking for? So you may be stuck with this. Lab computers, because of CLSI, which is their accrediting organization, they have to report things a certain way. They're not that flexible. We worked very hard at the VA and at UNM to limit the amount of reporting that our prescribers saw to direct them towards what we wanted them to do. So the thing to do here is to know what questions and what you're looking for in advance. So this is a Staph aureus isolate. Okay. Where did it come from? Skin or urine? So drugs that are appropriate for one site may not work for another site, as we discussed. We might be able to get high concentrations from one site, but not another. Is the isolate expected or unexpected? So Staph aureus in the urine is kind of unexpected. E. coli would be more expected. Look at the drugs by class. So what do I care about with Staph aureus? I care that this might be a MRSA. So how do I know that this is a MRSA? I see a ton of R's there, but there's only one I really care about. I want to look at oxacillin. MRSA stands for methicillin-resistant Staph aureus. The lab does not test for methicillin because it's not stable in those little microtiter plates we talked about. So they use the drug in the same class, which is oxacillin. So MRSA should really be ORSA. And you can see there it's resistant to oxacillin. So that already tells me I don't even have to look at Keflex or penicillin or ceftriaxone. This is an MRSA. Ciprofloxacin, even if it said S, I'm not going to use that because you can see development of resistance. So an MRSA, what am I interested in? What can treat an MRSA? Fairly short list of drugs. Bactrim, tetracycline or doxycycline, as we use most frequently, those would be choices for severe skin and soft tissue infection. In the blood, I would be using vancomycin. So you can see here, I don't need to look at all that garbage with imipenem and levofloxacin and nitrofurantoin. Those are not relevant drugs for this organism. So that's kind of how you need to start looking at your reports when they come in. This is E. coli in the urine, or Klebsiella in the urine. What in the report matters to us? So people often take one look at that and say, I don't have time to look at the whole thing. So it's important to set up in advance. When you get the resistance report, look at these three drugs that are on our protocol. So what shouldn't be in a urine culture, you're not really, yeast can often be there. It usually reflects a colonization from an indwelling catheter. Same with staph species, mixed culture. All of these are very suggestive that you didn't take out the catheter, that had been in for a while, and then you had a colonized catheter with all kinds of skin and enteric species, because we all have yeast in our bowel as well. So how about some gram-positives in the urine can be meaningful. This was a tricor gram-positive urine antibiogram from a few years ago, looking at Enterococcus. And you can see there we had, and Staph aureus, so we had 60%, again, susceptible to oxacillin in the Staph aureus, so 40% MRSA resistant. I'm only looking at one column for that, really. And then Enterococcus, it is 88% susceptible to penicillin and ampicillin 90%. So we also had a lot of messaging for Enterococcus talking about If you had bloodstream infections, you needed an aminoglycoside as well. You won't be using that in long-term care. And you can use ciprofloxacin for Enterococcus in the urine, but really no other site. Staph aureus in the urine. So this is kind of a bugbear. If you have patients with indwelling catheters, Staph aureus can be present in the urine and cause a localized UTI. However, it's very important to realize that Staph aureus in a patient with fever or systemic infections will often travel around the bloodstream and then lodge in the kidneys and show up in a urine culture, especially in a patient without a catheter. So Staph aureus urinary tract infection in a patient without a catheter is really a scary thing, because the patient may have an infection elsewhere, like a bloodstream infection, bone infection, heart valve infection, that is just not that apparent and is hard to diagnose. So a classic scenario that we would see, patient would come to the ER with a little bit of fever. They would do a dip on the urine. It would be a little bit abnormal. They would send the urine culture. They would put the patient on Cipro. So the Cipro would kind of if it was not an MRSA, it would sort of treat the bloodstream infection for a few days, but then the patient would come roaring back with high fever, very septic, positive blood cultures. And what they had in fact done is just mask a bloodstream infection. So many of your patients who are recent discharges from the hospital may have been seeded with Staph aureus through a peripheral IV, other medical interventions. Be aware, Staph aureus really shouldn't be in their urine unless they have long-term urinary catheters and are clearly just colonized, but watch them carefully for fever. And don't assume that it is a true Staph aureus UTI. So gram-negative antibiogram, look at your year-to-year trends. Look at what's going on with fluoroquinolone susceptibilities with your E. coli and Pseudomonas, because if you use a lot of those drugs, you will lose them very quickly. So just important to put in the context of how the patients are moving through healthcare. So in long-term care in the community, we're seeing a lot of fluoroquinolone use, treatment of colonization, not infection. Patient may also have a viral infection, as we alluded to, can cause pretty severe disease in elderly people, even when it's not influenza. Then they wind up in acute care and long-term acute care. They get a lot of beta-lactam drugs, piperacillin, tazobactam, ceftriaxone. Then you get the more resistant gram-negatives that we'll talk about, extended spectrum beta-lactamase gram-negatives. And then people turn to carbapenems, imipenem. And then we see patients get colonized with imipenem or carbapenem-resistant bacteria, and then they get spread around. There's also a new oral carbapenem that could really amplify this risk, because it would work right in the bowel where these bugs are hanging out. So I call this sequential enrichment for the really resistant organisms. So it's very important at the very beginning of this cycle not to bump the patients up to broad spectrum antibiotics where they're not necessary, and look at your antibiogram and see what you can reasonably use. So here's some scary things you might see on lab reports. Extended spectrum beta-lactamases. For these patients, you cannot treat them with, say, ceftriaxone, third-generation cephalosporins. You want to discuss them with somebody who you want to look at what they're getting for antibiotics, and you want to isolate them because you're already on the step of developing more resistant organisms. CRE. Here's one of the scary superbugs, carbapenem-resistant Enterobacteriaceae. So the Enterobacteriaceae are all the family of organisms in your bowel, E. coli, Klebsiella, Salmonella, and these are the organisms that in patients in the hospital who get invasive bloodstream infections, they do not do well. So they can be sitting in your nursing home with this in their bowel, and then if they get admitted and something happens, like a ruptured diverticulum or something like that, and they get this in the bloodstream, the care team is often kind of behind the 8 ball because it takes a while for the lab to figure out just what is going on before they declare it a CRE. So they're resistant to not just carbapenems, but everything that goes along with that, 3rd-generation cephalosporins, extended spectrum penicillins. They've picked up everything along the way, and then they're transmissible to other patients by hand-to-hand transmission to the body of the other patient. So we have a special program. We have the Emerging Infections program here, and that allows us to do a lot of specialized bacteriology with Department of Health. The most recent report showed 183 case reports of CRE bacteria between June 2015 and May 2017. Half of them were Enterobacter species, Enterobacter cloacae and Enterobacter aerogenes. A third of them were E. coli, and then most of the rest were Klebsiella. Where were these guys? So these patients were largely reported from acute care hospitals, but they were also reported from long-term care facilities and outpatient settings. So it's pretty clear that a lot of the reports were not bloodstream infections. They were maybe urine infections. They were colonizations. But this tells us that we have a reservoir in our community that we don't want to get passed around. So if you see one of these reports, who calls you? Whom do you call? You might get a call from the lab. You might get a call from Department of Health. If you see one of these reports, you probably want to notify state epidemiology. The lab probably has already done this, but it doesn't hurt to have duplicate reporting, and that's the state epidemiology line. So why do we report? There is a plan in development for CRE in New Mexico. It's very important that these patients' histories follow them from facility to facility. For instance, if your patient who had a little CRE pop up in the urine culture and is not that sick, if they got admitted to hospital the next month, they're still carrying the CRE. If they wound up in the ICU in that hospital, then everybody in that ICU rapidly will get colonized. So we had a similar bad bug at the VA with Acinetobacter back in the early 2000s, and it was quite astounding. The patient came from out of state to Arizona to our spinal cord injury unit, then moved up to our ICU and had a very resistant Acinetobacter, and these bugs are very tough in the environment. And it basically, when we looked at just clinical cultures from patients, sputum and urine, it went bam, 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 and it immediately colonized about 6 other patients in the ICU. So that's how fast they can spread on your healthcare workers' hands due to inadequate hand hygiene on the clothes, if they're not in contact precautions with workers using gowns and so forth. So here's a follow-up question to that. Our facility has a standard process or form for communication with other facilities that includes information on infection and colonization status, say with resistant bacteria. We're worried about resistant MRSA, resistant Enterococcus, resistant gram-negative rods. This has been a real challenge. Sometimes hospitals will develop these forms just with their local nursing homes. There's only one state in the country, which is New Jersey, where it's actually being mandated by the state legislature. And the fact of the matter is, when you're dealing with physicians in the hospital, a lot of them don't really see the importance of putting down the resistant organisms. They're focused on the discharge form with the level of care for the patient, the medications, the discharge summary, and getting this extra stuff included about their organism status or their recent infection with C. difficile is a struggle to get that included. So I'm not surprised that people do not have this available to them. So there is a requirement, okay? So the long-term care requirement that went into effect November 28th, 2017, is that there is a requirement for interfacility communication that includes, but is not limited to, isolation precaution information due to current or previous infection or colonization, the most recent relevant labs, medications, including when last received, advanced directive, and comprehensive care plan goals. So the isolation precaution information is right there, and you have to give it when you send the patient to acute care, and they have to give it when they send it to you, send the patient to you. So look at what you've got. Make sure that this is getting included when you readmit and when you get patients from the hospital. Everybody really needs to participate in the sharing of information. Otherwise, we're just going to spread these organisms even further around our healthcare system. So one healthcare system, this gives you an idea of what it takes to control these organisms. In Israel, they basically have set up a office in their Department of Health devoted to this, where they called every facility regularly to find out where the patients were. They knew all the patients that had CRE in a registry, and they tracked them all the time to know if they had readmitted and where they were. And so that's the kind of tracking that it takes. And they were successful in actually reducing the incidence of CRE in their population on a countrywide level. So any questions, discussion? I know that was a lot to take in with microbiology. I think the main thing is to develop some kind of framework as to how you're going to look at reports that come in and make sense of them and pick out the drugs that matter to you. So that's going to take some discussion in antimicrobial stewardship committee as to how you address the reports that come in and make sure that people feel comfortable looking at them for the essential information. Any comments out there?
There's nothing in chat right now.
Okay.
If you have questions about anything that Dr. Kelly has talked about up to this point, I'm sure she'd be happy to answer.
Yeah. I know that many people are looking at these reports that are difficult to follow, but when you start out with a framework where you maybe develop a cheat sheet for how you're going to look at a report and what matters to you, for instance, if I get back a Staph aureus, I want to know whether it's a MRSA so I can put that patient into isolation and add that to their chart. If I get back a urinary tract infection, I want to be able to look at the 3 key drugs that we've decided for our protocol and see what the patient's on and see if it's susceptible to those 3 key drugs, for instance.
We do have a question.
Yeah.
Will survey ask if we have a process for interfacility communication?
From my reading of this is direct from the what do they call it, the Federal Register. It looks like it is. They want a process for interfacility communication. Now, I know from my end on the acute care side that there was supposed to be a verbal communication, a live communication, not just a piece of paper, but actually a handoff. That could be obtained, for instance, by, as I know, many of the long-term care facilities have staff that go and review patients prior to admission, go to the hospital and find out about them. So that could be included there. But there has to be some kind of process where there is a verbal handoff on the part of the referring hospital. So I would have that discussion with the social workers that refer to you. And when a handoff is done and structured, the handoff should be done in such a structured way that the person listening to the handoff knows what's coming in the right order. So they know when to expect the medications, when last received, what the plan is for the patient in terms of duration of medication. This is all information that you have the right to when you receive a patient from a facility.
And we can check a little further to see if we can find anything specific on that. If we do, we'll post it as a question and answer with the webinar.
Right. But the referring facilities, it is supposed to be a verbal communication in addition to the piece of paper. And that makes a tremendous difference. So for the next session, we'd love to have a bit of homework. If anybody will share with us, we're going to be talking, this is our final session at the end of the month, Thursday, March 28th. We're going to be talking about sustaining good practices. So we're really interested to find out if anybody has done a process improvement surrounding antimicrobial stewardship, maybe ordering cultures, where you've gone through the process of examining your data, doing an audit, perhaps like auditing your use of C. diff testing, making sure none of the patients just got laxatives, whether you've kept a record of your bug-drug mismatches. It's really helpful to reward staff, recognize work. I've been in so many hospitals over the years, not so many long-term care facilities, but hospitals that are high-performing with their quality. They recognize their staff. They put things up in the hallway that say, hero of the month for preventing a drug interaction or medication error. These are all really important for your staff, and to also open a discussion and make it clear that you're interested in improving what you do. So if anybody has anything they'd like to share, there are outside venues where people can share posters of things that they've done, local meetings, and that's also really nice because you can disseminate to other people in your field what you've done. And that's what people really need, because it's not just reading articles or the literature that helps. It's knowing how people actually did things in real life. And you often don't find out from the literature just how they actually accomplished what they did. So it's really helpful for facilities to share what they figured out. So we'd love to hear if anybody has done a project.
So if you're interested in that, email me, aromero@healthinsight.org, and I will pass that on to Dr. Kelly. Okay, I don't see any additional questions or comments in chat. This session will be posted to our website within a few weeks, and once we send it out, please feel free to share the link with any of your colleagues who couldn't attend, or go ahead and use it as a training in service for your staff. Please complete a short survey to let us know how we did and what we can do to improve. Elaine has posted that link in the chat. And I'd like to thank Dr. Kelly again for her presentation today. As always, it was very informative. And if you have any questions or concerns that come up before the next session, feel free to contact me or Elaine. And again, if you're interested in providing us with some information on things that projects that you've done that have been successful, go ahead and email me and let me know. Thank you.